Maintaining a good patient-nurse relationship is essential, but it's not always easy. Whether you're on the front lines in the emergency room, working those long patient hours with the home health client, engaging with clients in the long-term care facility, or working in that psychiatric facility, how you interact with those that you serve has a big impact on that patient care. Your relationship with each patient is vital, and that's why it's important for every RN to take action to improve patient care and the overall experience. A patient-centered partnership implies that the patient participates in his or her healthcare decisions. This is something that we want to promote as the nurse, and we do this by forming this therapeutic relationship with our clients. The therapeutic relationship concept has been around for a while. Paplow actually introduced the concept of nurse-patient relationship and patient-centered care. Core concepts of this patient and family-centered care included things like dignity and respect, information sharing, patient and family participation, the patient's feeling of being heard and understood. All factors that have long been identified as part of the nurse-patient partnership. These patient-centered partnerships imply that the patient's participation in the healthcare decisions will occur, a collaborative patient-centered treatment planning. For the purposes here, the term nurse-patient partnership or nurse-patient relationship imply collaboration with the patient and the family regarding healthcare goals, how we meet those goals, plans to meet those goals, interventions within the patient's and the family's cultural and ethnic background and comfort level. The therapeutic nurse-patient relationship is the basis of psychiatric nursing treatment approaches regardless of the specific aim. This is how we make that first connection between us and the patient, trying to establish an understanding to the client that the nurse is safe, reliable, consistent, and that they'll keep the individual's information private. This is what we call the art of nursing. Before you've seen some of the cognitive skills, you've seen some of the technical skills. So here we're applying the art. And when we apply this art of nursing, it's a creative process that's unique and different for every nurse. Each nurse brings their own uniqueness to the relationship. They each have their own unique gifts that we can learn to use creatively to form positive bonds. This has been referred to traditionally as the therapeutic use of self. The therapeutic use of self is an example of that art of nursing. It's important to remember that by using this therapeutic use of self, scientifically, we've established that this has resulted in positive outcomes for the patient. On the other hand, when the patient doesn't develop this bond with the nurse, non-adherence and poor outcomes, the patient feeling unheard, disrespected, or disconnected with the nurse or the healthcare worker has been seen. There's a loose definition for the nurse-patient relationship, but a therapeutic relationship involving principles of mental health is more clearly defined and different from other relationships. The therapeutic relationship has specific goals and functions. The goals include facilitating communication of distressing thoughts and feelings, assisting patients with problem solving to help facilitate activities of daily living, helping the client examine self-defeating behaviors and test alternatives, and promoting self-care and independence. Relationships are an interpersonal process involving two or more people. As we go throughout life, we'll meet different people in a variety of settings and we'll share different experiences. We may develop long-term relationships with some and short-term relationships with others. The kind of relationship we develop will vary from person to person and situation to situation. Generally, relationships are defined as either social or therapeutic. Social relationships are relationships initiated primarily for the purpose of friendship, socialization, enjoyment, or to achieve some task. Mutual needs are met during a social interaction. Participants will share ideas, feelings, and experience. Communication skills in the social relationship sometimes include giving advice, meeting basic dependency needs like lending money or helping with a job. The content of the communication remains superficial. In the social interaction role, the role may shift. With the social relationship, there is little emphasis on evaluating the interaction. The therapeutic relationship partnership between the nurse and the patient is different from both a social and intimate relationship. The nurse maximizes their communication skills with understanding of human behavior and personal strengths to enhance the client's growth. The client will more easily engage in the relationship when the nurse's interaction addresses client concerns, respect for the client as a partner in decision making, and uses language that is straightforward. This suggests the focus of the relationship is on the client's ideas, experiences, and feelings. Inherent in a therapeutic relationship is the nurse's focus on significant personal issues introduced by the client during that interview. The nurse and the client will identify areas that need exploration and periodically evaluate the degree of change in the client. The nurse can assume a variety of roles, such as teacher, counselor, socializing agent, liaison. The relationship is consistently focused on the client's problem and the client's needs. The nurse must meet their own needs outside of this therapeutic relationship. When the nurse begins to want the client to like them, or do as they suggest, or be nice to them, or give them recognition, then the needs of the client is not adequately being met. The interaction could be detrimental or non-therapeutic to the client. When the nurse is working under the supervision of a more experienced nurse, we can keep focus and boundaries clear. So for new nurses, we might want to consider this. Communication skills and knowledge of the stages and phenomena occurring in that therapeutic relationship are crucial tools in the formation and maintenance of that relationship. When you provide a helping relationship for your client, you'll see the following. The needs of the client are identified and explored. Alternative problem-solving approaches are taken. New coping skills may develop, and behavioral change is encouraged. Often, staff nurses and nursing students will struggle with the boundaries between the social and therapeutic relationship. There is a fine line. Students sometimes feel more comfortable being a friend to a patient because the role feels more familiar, especially with people close to their own age. However, when that occurs, the nurse or the student needs to make it clear to themselves and the patient that the relationship is a therapeutic one. This does not mean that you're not friendly towards the client, and it doesn't mean that you're not talking about things like television, the weather, or children's pictures. It does mean that you follow the prior stated guidelines regarding the therapeutic relationship, essentially stating that the focus is on the client and the relationship, and it's not designed to meet the needs of the nurse. The client's problems and concerns are explored, potential solutions are discussed by both the client and the nurse, and solutions are then implemented by the client. Example, client states, "Oh, gee, I hate to be alone. It gets me down and it hurts so much." Nurse states back, "Loneliness can be a painful thing. What is going on now that you are feeling so alone?" And then, if you go into your book, you can read different excerpts here to see how that therapeutic conversation should transgress. By engaging in this therapeutic relationship with our clients, it also promotes independence. Now, in 1952, Paplow introduced this concept of nurse-patient relationship in her book called Interpersonal Relations in Nursing. It became very well accepted in the United States, and it became an important tool for all of nursing practices. So at that time, that nurse-patient relationship concept was highly promoted. This interactive nurse-patient process developed by Paplow is designed to promote the patient's boundary management, independent problem solving, and decision making that promotes autonomy. Any contact that you have with the patient that shows caring and respectful care will bring about a positive impact on that patient. Paplow described this nurse-patient relationship as an evolving relationship and stated that it occurred through 3 phases that were interlocking and overlapping. The distinctive phases of the nurse-patient relationship are generally referred to as the orientation phase, the working phase, and the termination phase. Various phenomena and goals are identified for each of these phases. However, they often overlap. Sometimes even before you first meet the client, the nurse may have her own thoughts and feelings or his own thoughts and feelings related to the first clinical session, and that is sometimes referred to as the pre-orientation phase. So, especially inexperienced nurses can have concerns and experiences regarding how they're going to approach or encounter certain patients, and that can bring about anxiety. So when you're working with psychiatric patients and you have that pre-conference, sometimes it can increase that anxiety. Sometimes nurses are afraid of certain people with certain psychiatric issues that they might say or do the wrong thing. And when you deal with psychiatric patients, there's really no specific words or any magic words. So sometimes just talking to a more experienced nurse can help build confidence in these newer nurses or these inexperienced nurses by giving them feedback and suggestions. Now, psychiatric patients, sometimes they can smell a new nurse. They smell that greenness on you. So you have to be careful of them because a lot of them have been in psychiatric facilities for a long time and they know how to manipulate the system. However, experienced psychiatric nurses and staff, we also monitor the atmosphere and we also can pick up on a client when they start to escalate, when they're about to engage in certain behaviors, or when we feel like a certain incident is going to occur. So we're trained in crisis intervention. I know your book says security is available. Sometimes you're security. So, it's going to really depend on who you work with, what the level of the psychiatric disorders with that patient are, and also sometimes it will depend on how violent that the client is, how much freedom that they have, or what sort of a facility that they'll go in. So for like the criminally insane people that have like murdered people or done extenuating circumstances, they're particularly kept usually at a certain facility that they don't have, access to certain items. Doesn't mean they don't ever get them, and it doesn't mean it can't happen, because we still have to monitor them closely and watch them. They're very manipulative, but typically they're kept in a place where they're going to have a lot more security than someone who's just schizophrenia that doesn't have any sort of a violent history. So there's going to be, ground rules that you're going to be given when you walk into one of these places. Like, one thing is that you're going to know that you don't enter the patient's room alone. And also, you don't let that client in the nurse's station when you're in there by yourself. So there's just certain things you're going to do or not going to do. And some places, they don't have cages, but cages are where the nurses stand in to give the medications. Now, if you're working in a true psychiatric hospital, you might have that. But if you're working in a place where people have dual diagnosis, you may not necessarily have one of those cages that you're giving medications out of. So you can do things like keep, the medication cart between you and the client, and being alert for specific behaviors. That is one of the most important tools that you can have, because if you could just sense and pick up on the behavior, a lot of times you could just prevent things from occurring by changing that environment, changing something in that environment, or just changing something in general. All right, so those are some of the kind of things that you'll learn, and you'll also learn, like, sometimes people will have certain physical symptoms, and when you see those physical symptoms start to occur, you know that something else may occur with that client as well. All right, so during the orientation phase, that can last for a few meetings, or it can be over a longer period of time. So in the beginning, the nurse and the client will be strangers, and so they're going to introduce to each other. They'll interact according to what their background, their values, and their experiences are. So each person will have a different or a unique frame of reference, and a need for self-awareness will be happening on the nurse. All right, so what that basically means is that you'll have to be aware of your own biases, your own feelings, how you're going to feel about this client, about some things they may tell you, or about some behavior they may engage in, which may or may not be appropriate, because a lot of times they don't engage in appropriate behaviors. All right. So things that you will be looking at during the initial interview are providing an atmosphere where the rapport can grow. You'll clarify your role as the nurse and what your responsibilities would be towards the client, as well as their responsibilities. The contract that contains the time, the place, the date, and the duration of meetings. So you'll talk about that contract and how it will be put in place. Confidentiality would be discussed and assumed. The terms of termination are introduced, so we're always talking about the termination phase and thinking about it from the very first time that we meet the client. And then we become aware of transference and countertransference issues. And we'll talk a little bit more about that in the slides coming up, about what they are, what the differences are. And then patient problems are articulated and mutually agreed. Goals are established. We'll build rapport during this. So we're trying to provide an atmosphere where trust and understanding can grow, and it facilitates the establishment of rapport. So we do this through genuineness, empathy, and showing consistency, offering assistance in problem solving, and providing support. Asking the client how they want to be addressed, and also making sure that we're showing respect, dignity, those kind of things. Also, the client needs to know about you, who you are, why you're meeting with them. All right. So you're going to tell them, hi, I'm Sue, I'm the nurse, I'm from the community college, I'm in my psych rotation, I'm here to evaluate clients for the next several sessions, and I'll be meeting with you while I'm here. Is it okay if I look at your book? These kind of things. And then you may have a formal or an informal contract. This emphasizes the client's participation and responsibility, and it shows that you, as the nurse, are doing something with the client rather than for the client. It can be either verbal or written, and it would contain the place, the time, the date, and the duration of the meetings that would occur. And during that orientation phase, the client would start to express some of the thoughts, feelings, identify problems, discuss realistic goals. Mutual agreement on the goals would also be part of the contract. So it would state something like, hi, Miss Thomas, we're going to meet at 8:45 every Wednesday in the consultation room at the clinic for approximately 1 hour, starting February 15th and going through November 18th. We can use that time to further discuss your feelings of sadness, anger, and explore some of the things that you can do to help make your situation better for yourself. And if you look at table 9.1, if you look at table 9.1 in your book, it'll give you some other ideas of how to engage with these clients. Now, you also want to discuss confidentiality with these clients. The client has a right to know who the information provided to the nurse would be shared with. They also need to know that the information is not going to be shared with people like relatives, friends, or others outside of that treatment team, except in extreme situations if it was absolutely needed for some way for treatment. All right, we have to safeguard the privacy and confidentiality of the client. That is your ethical obligation and a legal responsibility. An extreme situation would include things like child or elder abuse, a threat of self-harm to either themselves or someone else, the intention not to follow through with the treatment plan. If the information must be given to someone else, that would usually be done by the physician according to specific legal guidelines, which we'll discuss in Chapter 6. The nurse must also be aware of the patient's right to confidentiality and not violate that right. And then a termination phase, which begins in the orientation phase, may also be discussed during that working phase if the relationship is time limited. The date of the termination phase should be clear from the beginning, and in some situations, the nurse-client contact may be renegotiated when the termination date has been reached. In other situations, when a therapeutic nurse-client relationship is an open-ended one, the termination date may not be known. And then the working phase. The strong working relationship develops over time. It allows for the client to experience anxiety and demonstrate dysfunctional behaviors in a safe setting while trying new, more adaptive coping behaviors. Specific task of the working phase of the nurse-patient relationship is current clinical practices as follows: maintain the relationship, gather additional information or data, promote the patient's problem-solving skills, self-esteem, and use of language, facilitate behavioral changes, overcome resistance behaviors, evaluate problems and goals and redefine them as necessary, and help promote practice and expression of alternative adaptive behaviors. During that working phase, the nurse and the client will identify and explore different areas in the client's life that are causing them difficulty or problems. Often that client will present ways of handling situations that stem from their earlier means of coping devised to survive in some sort of chaotic or dysfunctional family environment. Certain coping methods may have worked for the client at earlier ages, but now they interfere with that client's interpersonal relationship and they stop the client or prevent the client from attaining certain current goals. The client's dysfunctional behavior and basic assumptions about the world are sometimes defensive, and the client is often unable to change that dysfunctional behavior at will or on their own. Most of the problem behaviors or thoughts will continue because they're not consciously aware of these motivations and needs, and so the behavior just continues to repeat itself. The nurse can work with the client to help identify these unconscious motivations and assumptions that keep the client from finding satisfaction and being able to reach their potential. By describing and re-experiencing, old conflicts sometimes become more heightened or more at our awareness. We can see them better, but it also can cause us more anxiety. So you have to be careful. Sometimes clients will use a defense mechanism against that anxiety and displace their feelings on to the nurse. So during the working phase, these intense emotions such as anger, anxiety, self-hatred, hopelessness, helplessness may appear. Defense mechanisms such as acting out inappropriately in an angry sort of way, withdrawing, intellectualizing, or manipulating or denying can be expected. Also, in that working phase, the patient often unconsciously transfers strong feelings into the present onto the nurse that belong to significant others from the past, a concept known as transference. This emotional response and behavior in the client can also awaken strong counter-transference feelings into the nurse, where the nurse's own personal feelings and reactions come out and are there then transferred to the client. The nurse's awareness of personal feelings and reactions to the client are vital to make sure that the interaction is effective. The termination phase is that final phase, okay, and it's an integral phase of the nurse-patient relationship. Termination is discussed during the first interview and then again during that working stage as needed. It will occur generally when the client is discharged or for the student when the clinical rotation ends. So tasks of the termination stage are summarizing the goals and the objectives that were achieved in the relationship, discussing ways for the client to incorporate into daily life new coping strategies learned during the time that was spent with the nurse, reviewing situations that occurred during the time spent together, exchanging different memories that can help validate the experience for both the nurse and the client, and facilitate closure of that relationship. The termination phase often awakens strong feelings for both the nurse and the client, and it can signify a loss for both the nurse and the client. Although the intensity and meaning of termination may be different for each person, if the person has unresolved feelings of abandonment, loneliness, or rejection, they may be reawakened during that termination process. Termination can be an opportunity for the client to express those feelings, perhaps for the first time. So the nurse and or the student must address certain things in the termination phase and taken into consideration. Okay, feelings can be aroused in both the client and the nurse with regard to the previous experiences they have shared or that particular experience. And when the feelings are recognized and shared, the client learns that it's acceptable to feel sadness and loss when they lose someone who they care for. The termination can be a learning experience, and clients can learn that they are important to at least one person. By sharing that termination experience with the client, the nurse demonstrates caring for that client. And it may be the first successful termination experience for the client. It's important for the nurse to help the client acknowledge any feelings and reactions that they may be experiencing related to separations. If the client denies that the termination is having an effect, the nurse can say something like, "Goodbyes are sometimes hard or difficult for people, and often they remind us of other goodbyes. Tell me about another separation that you had in the past." If the client appears to be displacing anger by withdrawing or by being overtly angry, the nurse can use generalized statements such as, "People sometimes experience anger when saying goodbye. Sometimes they're angry with the person leaving. Tell me how you feel about my leaving." Consider your last clinical experience with the client and work through feelings with your supervisor to facilitate communication. A common response of new nurses, especially students, is feeling guilty about terminating that relationship. And sometimes um, it can cause the student to do something or the nurse to do something inappropriate, like giving out their telephone number or making plans with the client after they get discharged. Continuing to see the client afterwards or exchanging letters. Maintaining contact after discharge is not acceptable. It is in opposition to goals of a therapeutic relationship. And sometimes the student may feel less guilty for using the patient for learning needs. They may maintain feelings of being important to the patient, or they may sustain some illusion that they're the only one that understands the client, and other rationales that they may come up with. So we don't want, the new nurse or the student to get caught up in that trap. So on your sheet there on the PowerPoint, you see a little graph there, and it shows the orientation stage there. All right. Just remember that the termination process is used to explore, after discussion with the patient's case manager, the patient's plans for the future. Let's discuss where the patient can go for help, what agencies would be able to help them in, so what sort of community resources would be out there for them, and who could help the patient best, who could help them find the best resources in the area upon discharge. So that also would be part of that termination process. So for social relationships, we talked about these a little bit earlier, and I'll just restate that these are primarily used for things like friendship, socialization, enjoyment, or achieving certain tasks. Mutual needs are often met during these social interactions where people share ideas, feelings, and experiences. Sometimes communication skills are used, and those type of skills are things like giving advice, or meeting basic dependency needs, such as lending money or helping out with jobs. Again, these sort of relationships would encounter a superficial level of communication, and the person's role may shift from time to time. So they may start out in one role and end up in another role. And then we have little evaluation of the interaction. And that's versus that therapeutic relationship where we use our maximum communication skills. We try to understand those human behaviors. We look at our own personal awareness and our own biases, and we use those, and we put our needs on those of the patient to help that patient grow and enhance their personal growth. We teach the patient to be independent, to use their own problem solving skills. We address those client needs. We make sure that our language is straightforward, and we're constantly focusing on what the client's ideas and needs are. Compare and contrast a social relationship and a therapeutic relationship regarding purpose, focus, communication styles, and goals. So use this chart and just write it out. That will help you remember for the exam in case you see some questions on there. Several patient behaviors can be encountered by the nurse in the clinical setting. Some of those positive behaviors are the patient demonstrates things like respect, information sharing, participation with them and the family, compliance, collaboration, trust, setting and staying within those boundaries, and then developing that positive alliance. And some of those negative behaviors would be lack of information sharing, disrespect, not complying with treatment, isolating or not collaborating, lack of trust, demonstrating a lack of clear and appropriate boundaries. So they're maybe not following those boundaries, and then a negative alliance. So we know we've formed that therapeutic relationship when we've been able to promote that therapeutic communication and make it happen. We're helping that client meet those needs by helping them develop alternative problem solving skills, helping them develop new coping skills. We're forming that helping relationship. We're promoting that independence. We're focusing on the client's problems. We're encouraging those behavioral changes or those responses, those reactions to the things that are happening around them. If the therapeutic relationship is not therapeutic, okay, then we're blocking some of that communication. We're not helping the client find alternative ways to problem solve or develop new skills. We're more controlling. So instead of giving them and letting them find their own possible solutions, we're giving them the solution. We're telling them the solution, or we're giving them advice. We're telling them what they should do. Instead of allowing them to make decisions, we're giving them decisions that they should make. So we're promoting dependence. And we're focusing on our own needs as opposed to those needs of the patients. And then we're also enabling negative behaviors. So some of those negative behaviors would be like getting getting the client to try to like the nurse, or getting the client is trying to find some way to please or give acceptance to the nurse. So a study done by Forchuk and Associates is still used today. This is a qualitative study of the nurse-patient relationship, and they looked at both therapeutic and non-therapeutic relationships. They also identified certain behaviors that showed progression of the nurse-patient relationship, as well as those that interfered with the development of the therapeutic relationship. And it looked at the importance of consistent regular private interactions with the client as being essential to developing this therapeutic relationship, as well as things like listening, pacing, and consistency. So data showed that when we use things like consistency, pacing, listening, initial impressions, comfort and control, and patient factors, those things all led to a more positive relationship. So consistency just means ensuring that you're always assigned to the same patient, that the patient has regular routine for activities. Interactions are facilitated when they're frequent and regular in duration, format, and location, and it also refers the nurse to being honest and consistent or congruent with what she states to the client or he. Pacing would be allowing the client to set the pace and letting the client's pace adjust to fit their moods. A slow approach sometimes helps reduce pressure, and sometimes we have to take a step back and realize that strong relationships take time to develop. Listening includes allowing the client to talk when they need to, becoming a sounding board for that client's concerns and issues. It's one of the most important skills that you have to master, and to be able to truly listen to a person and attend to what is behind the words is a learned skill. Initial impressions, so positive initial attitudes and preconceptions are very important in how the relationship will progress. Preconceived negative impressions or feelings towards the client will usually result in a poor outcome for positive growth of that relationship. If you go in feeling like the patient is interesting or challenging and you have a positive attitude, then usually it'll result in a positive therapeutic relationship. Comfort and control. By promoting patient comfort and balancing that comfort out, we show that we care, or that we care about the client, and it also helps keep a balance in the relationship that's not too strict or too lenient. Patient factors that enhance the relationship would include things like trust on the part of the patient and the client's active participation in the nurse-patient relationship. Now, two things that could majorly impede the development of a positive relationship, according to Chuck and Associates, were inconsistency and unavailability. So lack of content, infrequent meetings, meetings in the hallway on the part of the nurse, the client, or both, hindered the progress of that nurse-client relationship. The nurse and the client, if reluctant to spend time together and meeting times become sporadic or superficial, then we use the term mutual avoidance. This is clearly a lose-lose situation. When the nurse's feelings and lack of self-awareness aren't present, so let me rephrase that. When the nurse has these feelings or this lack of self-awareness, it can cause a lack of progression, meaning that if she has these negative preconceptions about who the client is, or negative feelings like she has fear or discomfort in the relationship, then it can cause avoidance, and it can cause frustration, and it can cause withdrawal from both her and or him and the client. So sometimes we don't know about the feelings, and sometimes we do. So sometimes those feelings of negativity can be a little unconscious in the nurse. So we just have to be aware of them because it can impede the relationship. So there are three characteristics that are believed to help promote growth and change in the client, and they help establish a therapeutic alliance or relationship. And those are empathy, genuineness, and positive regard. They're sometimes considered the intangibles at the heart of the art of nursing. So when we talk about empathy, we talk about, putting yourself in the other person's shoes, which is sometimes hard to do because even if you experience something that that person has experienced, it's never going to be exactly the same, because when you experience something, it's not just that you're experiencing that something at the moment, you're experiencing that something and everything else that you've ever experienced in your life that is similar to that something. Every bit of trauma, every bit of thing that's ever happened to you at life could come into contact with that experience at the moment, and that represents how you react to that particular experience or event. So, like, say for instance, if your child is killed in a motor vehicle accident or something, and they're like 16 years old, okay, how can I say to you, like, I understand how you feel, because even if I lost a child, I may not have all these other components that affect the way I feel or how I see this event in my life. So empathy is this complex concept, and it has a couple of components to it: moral, cognitive, emotional, and behavior. Okay, so it actually means being sensitive moment by moment, and we're sensitive to changing meanings in which that other person is feeling, that fear, that tenderness, that confusion, or whatever they're experiencing. So we're sensitive to those things that are happening to them. And so we put a central focus and we feel with them and we try to feel what they feel in their world. So if I was sympathetic about something, then I might say, oh, yeah, my mom died too. And now I'm putting the focus back on me and not really on the client or the client needs. But if I was empathetic, then I would say, oh, this must be really hard for you, losing your mom at this time. That would be more of an empathetic response. Empathetic is temporarily living in that other person's life. Empathy versus sympathy. In empathy, we understand how the other person feels. However, in sympathy, we feel the feelings of others, so the objectivity of the emotion is lost. There's a lot of confusion about empathy versus sympathy. All right, so just try to remember that we understand the feelings of others in empathy, but in sympathy, we feel the feeling of others. So when a helpless person feels sympathy for another person, that objectivity is lost. The ability to help that client in solving a personal problem ends. You can no longer help them because sympathy is associated with feelings of pity and commiseration. So, although they're considered nurturing human traits, they may not be useful in that therapeutic relationship. So, when you express sympathy, you're agreeing with another person, and in some situations, it can discourage the ability to explore additional thoughts or feelings that that person may be having. All right, so again, when we're empathetic, we put ourselves in that person's shoes to try to experience the feelings that they're feeling as opposed to reverting back to feelings that we've had from a previous experience of our own. Now, genuineness, that's our own awareness, our own feelings, our ability to communicate when appropriate these feelings. It helps us build trust. When we're genuine, um, whatever we're saying is congruent with everything that we're presenting. So our emotions, the way our body presents itself, the things that we say, everything matches. And when we're genuine, we listen, we communicate to others without distorting their messages. We're clear and concrete in the communications that we provide. We have to be genuine in our therapeutic relationship. It shows that we have the ability to use those therapeutic communications tools in a spontaneous manner. All right. And so we're not rigid, we're flexible, we're adaptable, and we have the ability to um, just be good at, I guess, navigating through what the patient is telling us and what they're going through at that moment. When we think about positive regard, this just shows respect. It's our ability to look at another person and through our actions, not necessarily our words, we're able to show that person that they're worthy of being cared about and that we recognize that they have these strengths and this ability to achieve certain things. So that is what positive regard is. So when we look at attitudes of nurses, one way that you might convey respect is having that willingness to work with the client. In other words, you take the client and the relationship seriously. It's not just a job to you. You're not just doing something because it's a task. It's something you have to do. But you're seriously concerned for the client. you really want to be part of this experience, you want to learn, that it's valuable for you. And the client will feel that naturally from you anytime that that's happening, because they'll feel that level of respect, that level of commitment and dedication. So we don't view our experience as a job, but as an opportunity. And then we take actions continuously to show that we respect somebody by being caring, attending, by not making judgment, and by helping our clients develop their own resources. Also, we do something called attending. Okay, this is a crucial part of a successful interview. So to succeed, we have to pay attention to the client in culturally and individually appropriate ways. Attending is a special kind of listening that refers to an intensity of being present or being with the patient. At times, just being with the person during that painful time can make a difference. Your body posture, eye contact, and body language are nonverbal behaviors that will show the degree of attending, and they're highly culturally influenced. The cultural components of body posture, contact, and body language will be discussed more when we talk about it in Chapter 8. So I believe I already recorded Chapter 8 for you guys, and that should be available on the server already. Personal opinions. So we have our own personal opinions, of course, and sometimes we express them, and it's not always appropriate to do so. Most of the time, it's probably likely inappropriate. If the client's taking drugs or engaging in risky sexual behaviors, then you might recognize that those behaviors inhibit that patient from living a more satisfying life, or they pose some sort of potential threat, or maybe they keep that patient from developing a certain relationship. But you don't want to label the activities as good or bad. That doesn't help. You're better to focus on exploring behaviors and goals that the client can work for, identifying thoughts and feelings that the client has that cause that behavior, and try to change those things to try to improve the client's actions or include their behavior. By judging the behavior, then it will interfere with the therapeutic communication. It will hinder the client's desire to want to communicate and interact with you. So, in order to eliminate judgmental thinking, we have to recognize first that we have this judgmental opinion in our mind, identify where or how we learned the response to the patient's behavior, construct alternative ways to look at the patient's thinking and behavior, and then try to redirect our own thoughts and behaviors. Because if we just try to ignore it, then it could continue to inhibit the relationship. All right, so we don't want to ever inhibit that therapeutic relationship. So we're going to try to find ways to make ourselves better so that we can help these patients better. Now, when we first meet that patient, okay, we want to establish that nurse-patient relationship, and part of that nurse-patient relationship is making the client, one, understand that it will be safe, confidential, reliable, and consistent, and that it will be conducted within the appropriate and clear boundaries. Sometimes transference and countertransference can kind of blur those boundaries. So when we have transference, this is a concept that was developed by Freud, and in this process, the person unconsciously or inappropriately displaces these patterns or behaviors and emotional reactions towards someone else, usually a person of authority, that was from a previous relationship or some sort of unresolved conflict in their life. And usually that figure of authority would be someone like their mom, their dad, or their significant other. So sometimes the patient might even say, "Oh, you remind me of my mom," or "You remind me of my sister," or "You remind me of my grandmother." So they might even make those kind of statements. Like in your book, if you look on page 107, it talks about the patient showing an example of transference, and the patient states to the nurse, "Oh, you're acting so high and mighty. Did anyone ever tell you that you're cold and an unfeeling machine, just like others I know?" Here are the patients really actually talking about their mother, but they're inflicting those feelings upon the nurse. So the nurse responds by stating, "Tell me about one person who was cold and unfeeling towards you." So again, in this example, the patient is experiencing the nurse, or the nurse is showing or maybe doing things that are similar to what the client's mother did. And so the nurse reminds her of the client's mother. So the mother was aloof and left the client with feelings of isolation, worthlessness, and anger. And those are feelings that the client never resolved. They're conflicts that the client never resolved. So they use transference, and they're reflecting the emotions that they feel about the mom onto the nurse. So this transference phenomenon can occur in all relationships. It seems to be more intensified where there is a relationship of authority, and clients do look at us as figures of authority because of who we are as nurses. We're respected. We have a certain body of knowledge, and we have this art of being able to interact with them. So they take us serious and they look at us in a certain light. Also, physicians and social workers, other people can be looked at as figures of authority as well. We're all potential objects of transference, and we have to recognize that the patient may experience certain thoughts, feelings, or reactions towards us. Now, they may have other thoughts, feelings, and reactions towards us that are realistic and appropriate. Those would not be considered transference phenomena. Some common forms of transference include the client's desire for affection or respect and gratification of dependency needs. Transferential feelings the patient might experience would be things like hostility, jealousy, competitiveness, and love. And they might also ask for special favors like cigarettes, water, or extra time in the session. Now, countertransference, this talks about the nurse. Okay, sometimes the nurse will displace their feelings onto the patient, and it's usually a reaction to the patient engaging in the transference. So the patient directs their transference onto the nurse, and the nurse's reaction is this countertransference. So it's normal to feel angry if you're persistently attacked or annoyed or unreasonably frustrated, or if you're flattered when someone is constantly idealizing you. The nurse might even feel extremely important if a client is dependent upon them daily for certain needs. Sometimes the nurse doesn't recognize their feelings as being countertransference. Sometimes they encourage independent growth in the patient, and sometimes they inhibit that independent growth. We have to recognize the countertransference reaction because it impairs our ability to have a productive therapeutic relationship in with the client, and it can cause harm to the relationship. It also can disempower the client by not allowing them to make their own decisions or be independent. If the nurse has a strong positive or strong negative reaction to the client, the feeling would signal some sort of countertransference in the nurse. Another sign of countertransference would be over-identification with the patient, where the nurse has difficulty recognizing or understanding problems that the patient has that are similar to her own or his own. For example, a nurse that's struggling with an alcoholic family member may be disinterested, cold, or disgusted towards an alcoholic patient. Other indications of countertransference can happen if the nurse becomes involved with power struggles, competition, or arguments with the client. So we have to identify and work through both transference and countertransference in order to achieve both professional and clinical growth and to allow positive change in the client. So we can do this through the use of supervision by either peer groups or the therapeutic team, and just through practice. So again, our roles and boundaries can be blurred when we don't recognize that the transference or the countertransference is occurring. So transference is when that person unconsciously or inappropriately displaces or transfers their emotional reactions that originated from some significant figure in childhood, like a parent, okay? And the reason why we say the parent, because in childhood, that's their significant figure or significant others. It could be also from a significant other, like a lover, a husband, a wife, or a boss. Okay. So the client says, you remind me of, and then they state someone, my boss, my husband, my mother, my teacher. All right. And then countertransference is when you, as the nurse, displace your feelings related to people from your past onto the client. And again, a lot of times it's the client's transference that causes the nurse to come with the countertransference. All right. So the patient's transferent to the nurse evokes, and then the nurse starts to have those feelings of countertransference. So, in other words, some previous exposure or experience of hers now starts to come alive and be displaced onto the client. So again, she's taking her feelings of from some other relationship with someone else that the client has reminded her of now and placing them on to the client. So, although the boundaries of the nurse and patient relationship are generally clearly defined, they can become blurred. That blurring can be insidious and may occur on the unconscious level. Usually, the transference and countertransference phenomena are operating when those boundaries are blurred. So, when we talk about attending, we're really talking about how present you are, how in tune you are with the client. The patient will perceive that the nurse is there for them and this human connection is made. So being present requires entering that client experience, and certain behaviors will show that client that you're truly engaged. And that would include things like active listening skills, body posture, eye contact, touching, or giving attentive physical care. It's done through effective communication, and we really understand that person's experience, fears, perceptions, and concerns. These attending behaviors are learned and they're inherent in this therapeutic relationship. Body posture, eye contact, and body language are nonverbal behaviors that reflect the degree of attending, but they're highly culturally influenced. The cultural components of body posture, eye contact, and body language are covered in detail in Chapter 8. Among people from similar cultural backgrounds, there may be a variation with an individual and what they're comfortable with in terms of eye contact. For some clients or interviews, sustained eye contact is normal and comfortable, but for other clients or interviews, it may be more comfortable and natural to make brief eye contact but look away much of the time. For most nurses to maintain more eye contact when the client speaks and less eye contact when the nurse speaks. However, in general, Caucasian patients are more comfortable with more sustained eye contact much of the time. Native Americans, Asians, African Americans prefer less eye contact. Body language involves two elements, kinesics and proxemics. Kinesics is associated with physical characteristics like body movement or posture, the way someone holds their head, legs, and shoulder, facial expressions, eye contact or lack thereof, and so on, convey a multitude of messages. For example, a person who slumps in a chair, rolls the eyes, and sits with the arms crossed in front of the chest can be perceived as resistant and unreceptive to what someone else wants to communicate. On the other hand, positive body language often includes leaning in slightly towards the speaker, maintaining that relaxed, attentive posture, and maintaining direct eye contact as well as hand gestures that are unintrusive and smooth while minimizing the number of other movements, matching your facial expression to the feeling or the client's feelings. Proxemics refers to the personal space, what distance between yourself and others is comfortable for someone. Proxemics takes into account that differences may occur between different cultural groups. Intimate distance in the United States is up to about 18 inches and is reserved for those that we really trust and with those that we feel the most safe. Personal distance 18 to 40 inches for personal communications, such as that with like friends or colleagues, and then social distance 4 to 12 feet for strangers, acquaintances, often those that we meet in public places or in some sort of formal social gathering. Public distance 12 feet or more would relate to a public space like public speaking. Vocal qualities or paralinguistics is how loud our voice is, the pitch, the rate, or the fluency. And believe that effective interviewers use different vocal qualities to enhance rapport, communication, interest, and empathy, and also to emphasize special issues or conflicts. So it's not what you say, but how you say it. Speaking in soft or gentle tones is more likely to encourage someone to share their thoughts and feelings, whereas speaking in a rapid or high-pitched tone can convey anxiety and create anxiety in the client. Example, how tonal quality can affect communication is a simple sentence like, I will see you tonight. So just by saying a simple sentence like, I'll see you tonight, how we say it, how we communicate that to a person, their perception of how we say it can affect their reaction to that statement. Verbal tracking is just that. Tracking is what the patient is actually saying. So clients don't know if you're hearing or understanding what they're saying unless you give them some sort of cue. So verbal tracking is providing neutral feedback by either restating or summarizing what the client already said. It's not about giving your personal or your professional opinion of what the client said. So in an example, you're just restating or reflecting what the client says. So the client says something like, I don't know what this fuss is about. I smoke marijuana to relax, and everybody makes a fuss. And the nurse states, do you see this as a problem for you? The client states, no, I don't. It doesn't affect my work. Well, most of the time anyway. I mean, of course, I have to think things out and make important decisions. Then obviously it can get in the way, but most of the time I'm cool. And then the nurse states, so when important decisions have to be made, then it interferes. Otherwise, you don't see it affecting your functioning. So the nurse is trying to restate or reflect what the client is stating there. That helps to pace the interview, that verbal tracking. All right, and it sticks close to what the patient's volume and tone is stating, and it also stays in line with the topics, that the patient is introducing. Hopefully the patient doesn't introduce too many topics at once because, sometimes that could be difficult for the nurse to follow. Eileen works with a youth in a residential treatment center when Amber, a new patient of hers, does not want her parents to visit. Eileen says, I know how you feel. Did your dad molest you too? Eileen's reaction is an example of which behavior. So we have empathy, verbal tracking, counter transference, and positive reinforcement. And if you stated counter transference, that would be correct. This is an example of the nurse displacing her feelings onto the client. All right, so now you're ready to do your clinical interview. The client is going to lead this. Okay, you will put those communication skills in place, that active listening, so that you can understand what's going on with the client and really totally encapsulate their situation. During that interview, you're going to give an opportunity for the client to reach specific goals, including to feel safe, to feel understood and comfortable, to identify healthy ways of meeting their emotional needs, and also to experience a satisfying interpersonal relationship. So prepare for the interview. One of the things that you want to take into the highest consideration is allowing this client to set the pace, let them go at their own pace. That's one of the most important things to stop the impediment of that therapeutic relationship. Okay, so you're going to let the client set the pace of the interview, no matter how slow you think the progress may go. So, in order to do that, you want to make sure that you set time aside to do this interview where you're not going to be rushed or where you're not going to be interrupted. All right. Effective communication can take place just about anywhere, but make sure that the setting, okay, is one that makes the client feel safe. So it has to feel secure and safe for that client, and it should provide quiet and privacy. All right. And then the environment itself, you want it to be comfortable. In these settings, the chairs should be arranged so that the conversation can take place with a normal tone, with normal voice or eye contact, so that eye contact could be either comfortably maintained or avoided. So things that you would do would make sure that you both have the same height, you and the client, right? You're either both sitting or both standing. That you don't have this face-to-face stance when possible. You want to have a 90 or 120-degree angle by some sort of side-by-side position to be less intense. So it doesn't look, confrontational. You have the ability, the client has the ability to look away. You're providing safety and psychological comfort in terms of being able to exit the room. The client shouldn't be positioned between the nurse and the door, and the nurse shouldn't be positioned in a way that the client feels trapped in the room. And then avoid a desk between the client and the nurse because that can make for a barrier. In the orientation phase, we're telling the client who we are, what the purpose of our meeting is. We're introducing ourselves. We're telling the client, what our expectations are, how long those meetings are going to occur, and we're also addressing the confidentiality and the privacy that we're going to provide. And also, we can tell them, that we have to respect privacy, personal privacy, confidentiality. However, in certain circumstances, like child abuse, if someone's presenting harm to themselves or others, elder abuse, those kind of things, we would have to report it. We're also talking to the patient and asking them how they want to be addressed. okay? And we're showing respect. We're giving the patient control over certain issues, allowing them to be addressed the way that they want to. And then as we're initiating that interview, once we've made those introductions, we now can turn the interview over to the patient by using some open-ended statements such as, where should we start? Or tell me a little bit about what's been going on with you. Tell me about your difficulties. Communication can be facilitated by offering the appropriate leads, statements of acceptance such as go on, or other statements that convey some sort of interest. And then we can also make statements of acceptance, which would be, go on, tell me more. Okay. And then you would want to avoid certain other behaviors as well. When you're speaking to the client, you want to speak briefly. When you don't know what to say, don't say anything. When you're in doubt, try to focus on the client's feelings. Don't give the client advice. Don't rely on questions. Make sure you pay close attention to any nonverbal cues and make sure you keep the focus of the conversation on the patient. You would want to avoid things like arguing with the patient, all right, or challenging them. Don't give them false reassurance. Don't try to interpret or speculate on what the client's saying. Use silence and allow them to, control that pace and say what they need to say. It may take them a little bit of time to get the information out. Um, don't question or probe the patient. So don't be an investigative reporter, okay? Pay close attention to those nonverbal um, communication cues and try to keep their anxiety down. Don't try to sell the patient on accepting treatment. Tell them about the available solutions, but let them make their own decision. And don't join in on attacks that they launch against their mates or parents. Try to focus on nonverbal communication and what they're saying. Also, don't participate in criticism about another nurse or another staff member. Again, focus on what they're saying, their body language. If there's some serious accusation or some threat made against someone, then you have to take that into consideration. Our values can affect the way that we interact with people. When we engage in different relationships, we bring preconceived thoughts, feelings, beliefs, and attitudes that are influenced by either our family, our culture, or our spiritual belief, and they form these values. Now, values are abstract standards and they represent an idea that is either positive or negative. It's usually culturally oriented or influenced in some sort of way through people that we consider role models, like our parents, our teachers, our religious institution, our boss or our workplace, our political leaders, films, media. All these things influence our values and form our thoughts about how we believe about certain things. Modeling is one of the most influential means of value because it is an example of the value in action. We all rely upon these role models to guide us in many of life's choices. Young people are especially influenced by different role models in their life. And so some of those role models will be people like their peers, other adults, athletes, rappers. As nurses, parents, bosses, coworkers, etc., teachers, we're constantly either a positive or a negative influence or a role model to someone else. Our culture and our own subculture defines the guidelines that provide structure to our life. And so it, dictates our beliefs, our thoughts, our behaviors, and our feelings and how we interpret them. Cultural values and beliefs provide meaning to our life and our environment in the form of how we operate or how we interpret things. and how we view the world or how we're supposed to behave, think, believe, or live are influenced by that interpretative system. Problems arise when the interpretative system of the nurse and the client are, black and white or completely opposite or significantly different. So the nurse is then working with someone who is completely culturally distinct from what her or his interpretation system is. And that may cause a problem in the nurse being able to connect with the client in a meaningful way. So we have to develop cultural self-awareness. That starts with being able to accept differences in what we consider normal, interesting, or desiring aspects of a human being. It's also very important that we have an understanding of our own values and attitudes so that we're aware of personal beliefs or attitudes that interfere with our working or therapeutic relationships. When we're able to recognize that our beliefs and values are not necessarily the right ones or not necessarily the right choice for everyone, then we are able to connect easier with those patients. It's also helpful to realize that our beliefs and values reflect our own culture and subculture, and many of them come from a range of choices or things that we've chosen for ourselves based on certain influences or role models. Those chosen values guide us in decision making and taking actions that we hope to make our lives meaningful, rewarding, and fulfilled. When we interview or work with others whose values, beliefs, cultures, or lifestyles are radically different from our own, it is often challenging. And a lot of topics that we face may cause controversy in society or in general. And that can include things such as religion, gender roles, abortion, war, politics, money, drugs, alcohol, sex or sexual orientation, practicing corporal punishment. These things can cause conflict between us and our clients. So we emphasize that the nurse and the client identify outcomes together that meet the patient needs. Okay, what happens when your values or your beliefs or your interpretative system is different from that of the client? Then certain conflicts may occur. Just be aware of these conflicts. So things like the client wants an abortion, but it's against your values. You believe that the client was raped and became pregnant and should get an abortion, but the client refuses. The client engages in unsafe sex with multiple partners, which is against your concern for safety and values. You, as the nurse, cannot understand a client who refuses life-saving treatment on religious grounds. The client puts material gain and objects ahead of loyalty to friends and family in direct contrast to the nurse's values. The client is deeply religious, where the nurse has difficulty with organized religion, relating to an experience with the religious cult. And the client's lifestyle includes taking illicit drugs, which is against the nurse's values. The nurse can develop working relationships and help clients resolve problems when the client's values, goals, and interpretative systems are different from her own by using self-awareness. This is understanding that what we value and what we believe guides our behaviors. If we understand and accept our own values and beliefs, but we're also sensitive to and accepting of the unique and different values and beliefs by others, then we can improve our therapeutic relationship with those people. This is another area by which supervision by a more experienced colleague can provide invaluable uh, information and knowledge to us. Personal values can change over time and over the course of a lifetime. So the values that you held as a child are likely different from those that you now hold as an adolescent and may continue to change as you grow. Take the cultural competency test to see how you can improve your quality of services and how you fare. Go to YouTube and search the phrase cultural competence self-test for a fun, informative, and short video. Meaningful therapeutic relationships are formed when values and cultural influences are considered. It's the nurse's responsibility to seek and understand the patient's perceptions. And most of the time, you're going to do this by engaging in your own self awarenesses, looking at your own biases, your own cultural preferences, and who you are. Because he works with a young man in a treatment center for domestic abuse, Ernesto is always careful to be respectful of both patients and staff, especially women. He tells a coworker, which educational tool is Ernesto demonstrating most clearly? The answer here is modeling. Modeling is one of the most potent means of value education. It presents a vivid example of values in action. We all need role models to guide us in negotiating life's many choices. As nurses, parents, bosses, and coworkers, friends, lovers, teachers, etc., we are constantly in a positive or negative manner being a role model to others.